Good evening, respected panelists, and especially participants. Welcome you again. After Eid, we are today's excellent lecture from our favorite, my elder brother and renowned international cardiologist in Bangladesh, Dr. Kaiser Nasrullah Khan. He will talk on advanced technologies in coronary intervention. We are eagerly waiting. I think not only fellows, all the faculties were excited to hear you from one of the young, aggressive intervention cardiologists in Bangladesh. Welcome, Dr. Kaiser Nasrullah Khan. Also, Professor Abdul Wadud Chowdhury sir, especially Mohsin sir, Mohsin sir, Dr. Wadud Shams Manwar, and Urmaski from Nepal. Wadud sir, please give your opinion and some talks. Yeah.
Good evening and assalamu alaikum everybody. This is the first time we are meeting after Eid al-Adha, and so good wishes for everybody. Today we are going to have a talk on intervention from Dr. Kaiser Nasrullah Khan. Well, he has made a name for himself in two respects. He's fearless and he's very adept in using newer technologies in the intervention. And unless he was fearless, he would not have been able to do that. And he's doing that quite nice. The young generation, who will be treating us when we are getting older, they'll be learning from masters like him. I hope today's lecture will interest many of the youngers to progress in that pathway, which way Professor Sufiya Rahman, Professor Momnik Jaman, and many others, including the late Abdul Khan Chowdhury, has shown us to progress. Ladies and gentlemen, Dr. Kaiser Nasrullah Khan.
Thank you, Wadud bhai, for your kind words. You are like a big brother for all of the cardiologists. Everyone, assalamu alaikum and good evening. Really honored to give a talk in front of such a learned gathering. My today's topic is advanced technologies in intervention, the topic is given to me by IPDI. I have nothing to disclose. I would like to express my heartfelt thanks and gratitude to Incepta, who is sponsoring such a nice webinar so that we can learn from each other and treat our patients better. And they're exporting medicine like 170 countries throughout the world. We're proud of you. At first, I would like to pay my homage and my heartfelt gratitude to my teacher, Professor A.H.K. Chowdhury, and also Dr. Manwar, my junior, Dr. Moin, the cardiologist of Sylhet, and more than 100 doctors who laid down their lives in fighting corona and treating general people and also us. May Allah bless all of them, Jannah. Now, advanced technologies, what does it mean? What is advanced technologies? Of course, in this modern era, what we meant by science advanced technologies are gadgets. And a small boy like him now saying, they say no phone inside the school. Today, school is inside the phone. So they are all doing online classes. And I would like to start my lecture by sharing with you my real life story, a bit sad story. And the story starts with these advanced technologies, that is gadgets. Here is my story. I have to share my iPad with my two girls for online classes. But unfortunately, they are always busy with games rather than books. Don't bother about surrounding or me while I coming from office, taking their picture. Just they're out of the real world, glued to gadget world. One day, surprisingly, I found them with books. When I was taking picture on that day, they are conscious that they hide their face as they are not well dressed. I was so happy to see them coming back to real world from gadgets. When looking for the reason behind it, I found my wife broke my favorite iPad out of anger as they are glued to gadget almost 24 hours. This is my broken iPad. I was furious, first on my girls, then on my wife, thinking what to do. Suddenly, I remembered a story. A person went to a doctor and said, every day my wife seems to lose her temper for no reasons. It scares me. The doctor replied, when your wife seems to get angry, just take a glass of water, swish, gargle it. Swish mani holo ki mukhe pani niye gargle korben, felte parben na gilte parben na. Don't swallow, just swish, gargle it inside your mouth till she calms down or leave the room. 2 weeks later, the man returned and said, that's a brilliant idea. It worked miraculously. How come a glass of water can do that? The doctor replied, the water itself does nothing. It's keeping your mouth shut. That does the trick. And I followed that advice. Took a glass of water, started swishing and gurgling to keep my mouth shut and calm down. So similarly, like this story of my real life, I got puzzled when I was given by the IPDI to talk about the advances in intervention cardiology. What should I talk? Because there are so many topics. Then, two angels come down from heaven. Professor Wadud and Dr. Mohsin Ahmed, who advised me to choose 7 or 8 topics on different aspects and start some of the advances of interventional cardiology today. And I would like to express my heartfelt gratitude and thanks to them also, because they built up a platform where the juniors can learn the knowledge and also experience from seniors and also between them, and it is gaining so popularity in such a short time for the sincerity and devotion of IPDI, not struggling for glamour, not struggling for who will be faculty, who will be sitting on the chair, who will be at first or second, but struggling for the knowledge and the good aim to teaching our juniors. Hats off to them. Now, as these two fellows advised me to cover this 8 topic for today. So I divided them into 2 headings. One is diagnostic and another is therapeutic. In diagnostic, there is 2 parts, anatomy and physiology. Anatomy 1 IVUS, 2 OCT, and physiology 3 FFR IFR.
Kaiser bhai শুনছেন Kaiser bhai?
আমি clear.
আপনি একটু আপনার স্ক্রিনশটটা অফ করে আবার ঢুকেন। আপনার এখানে অনেকগুলো দাগ পড়ে গেছে, হ্যাঁ? এখন শুরু করতে পারেন।
Okay. So, am I clear, Mohsin?
Yes, এখন clear.
যে টপিকগুলো আজকে আলোচনা করব, যেগুলো আমাকে মহসিন বা উদুল সাজেস্ট করেছেন, টু স্টার্ট উইথ দ্য অ্যাডভান্সেস, আমি দুইটা হেডিংয়ে ভাগ করেছি, ডায়াগনস্টিক এন্ড থেরাপি। ডায়াগনস্টিকের মধ্যে আছে অ্যানাটমি এন্ড ফিজিওলজি, অ্যানাটমিতে আছে আইবাস ওসিটি, ফিজিওলজিতে আছে এফএফআর আইএফআর, আর থেরাপিউটিকের জন্য অ্যাকিউট এন্ড ক্রনিক। অ্যাকিউটের মধ্যে থ্রম্বোসাকশন আইআইভি, আর ক্রনিকের মধ্যে গাইড এক্সটেনশন ক্যাথেটার, রোটাব্লেশন, লেজার থেরাপি। I will try to discuss all of them with one real life case example. Let's talk business. So, প্রথমে বোঝার আগে you have to understand two things. One is physiology, এটা FFR IFR দিয়ে আমরা করি. The question we want to know, should I treat the lesion? And second is anatomical or intravascular imaging, যেটা আমরা বলি, how would I treat the lesion more sophisticatedly? Where do you stand till now about this FFR, IFR, IBUS or OCT? FFR is a class 1 indication when evidence of ischemia is not available before angiogram, or for the intermediate lesion, whether we should do it or not, stent it or not. About IBUS OCT, it is class 2A indication, especially to know the reason for stent failure and to optimize stent implantation. To understand the anatomy, we can take example of a camera. The more the camera is increasing megapixel, the clearer the picture, like this sunflower picture. So starting from CT angiography to angiogram, then IBUS, then OCT, we get a clear picture, anatomical details of coronary artery. Let's talk about IBUS first. IBUS means intravascular ultrasound. এখানে প্রিন্সিপাল খুব সহজ, তিনটা জিনিস। একটা হলো গিয়ে IBUS ক্যাথেটারের মধ্যে একটা ট্রান্সডিউসার রোটেট করে এবং সেখান থেকে আমরা একটা আল্ট্রাসাউন্ড আমরা ছাড়া হয়। সেকেন্ডলি এই সাউন্ড ওয়েভটা গিয়ে টিস্যুতে রিফ্লেক্ট হয়ে আবার ফিরে আসে নর্মাল আল্ট্রাসাউন্ডের মতো, এবং অ্যাকর্ডিং টু ডেন্সিটি অফ দ্য স্ট্রাকচার, intima, media and externa or the pathology, এই ইম্পালসগুলো অ্যানালাইজ প্রসেস হয় থ্রু এ কমপ্লেক্স।
Do you hear me? Lots of Malaysian and Nepali students here, so please English is better than. Sorry for interrupting.
Okay, sure.
Thank you.
The intravascular ultrasound works in three principles. One is, number one, IBUS transducer rotates and pulls back through an area of interest, and it emits sound wave, ultrasound wave. These sound waves are reflected or pass through structure dependent on the density or acoustic impedance. And third is, these electrical pulses are then analyzed and processed by a complex computerized imaging system and then displayed on screen. So these are the basic three principles how the IBUS works. Now, in any method or any form of doing anything, if you want to understand the depth, you have to go for the basics. And similarly, if you want to understand IBUS and OCT, you need to know the basic anatomy. That our coronary artery has got three layers: intima, media, and externa, or adventitia. And between in intima and media, there is a thin internal elastic lamina, and between media and externa, there is another external elastic lamina. And remember, all the pathology happens in intima, between intima and it does not usually crosses the media and adventitia. So you have to know this intima very carefully and look into it very carefully, because there is all the problems, the atheroma, dissection, or calcification, everything happens usually here, rarely in media. So if you look at IBUS, you can see black and white picture like this. You can see the thin layer is intima, the first layer inside the vessel, and then you can see a radiolucent zone, a black zone which is media. This is radiolucent zone. And then again, a echogenic zone, which is adventitia. So the media is black, the intima is usually a bit of echogenic, and adventitia is most echogenic. Now, what are the clinical application of IVUS? 1, diagnostic. 2, interventional. 3, research application. Diagnostic, we need to determine the severity and extent of atheroma, quantification of luminal dimension, intimal thickening, assessment of plaque burden, and also assessing aneurysm, osteal and bifurcation disease. And you have to know there are 4 types of plaque. One is soft plaque, fibrous plaque, calcified plaque, and mixed plaque. Soft plaque looks in IVUS less echogenic than adventitia. Fibrous plaque is almost equal to adventitia. Calcified plaque are more echogenic than adventitia, and of course after that there is an acoustic shadowing. That means that after that plaque echogenic shadow, there will be a negative shadow or black shadow, which you won't find in the fibrous plaque. Mixed plaque means it has got both soft and fibrous plaque, or maybe sometimes a bit of calcium as well. So we have got these 4 types of plaque, which I have just now described. You can see the IVUS finding. And next thing we see, we use IVUS during intervention. What are the things we look for during intervention? These are the 3 things we look for. One is pre-intervention assessment. Second is stent deployment. Third is complication and post-procedural assessment. So before intervention, we see what is the composition of plaque. Is it hard plaque or soft plaque, or there is calcium or not, to know our strategy. To identify reference segment, pre and post stenotic normal vessel, and choose the stent size by measuring the internal luminal diameter distal to the stenosis. Next is stent deployment. We confirm where is the landing zone and determine expulsion of the stent. Usually it is very important because nowadays we do sometimes stenting without any contrast, zero contrast angioplasty, especially the CKD patients. So there we use IVUS to confirm the landing zone. And also the expansion of the stent, which is very important for restenosis. And now it is said that if we can keep minimal stent luminal area more than 5 square meter, there is less likely to be restenosis. And last point is complication and post-procedural assessment. We will identify edge dissections, we will identify proper apposition of the stent, and identify reference segment disease. Please keep this picture in your mind while putting your stent with IVUS. So you can see their reference segment both proximally and distally. And if there is a dissection which is less than 60 degrees and less than 2 millimeters in length, just don't stent it. Leave it like that. It won't do any SAT. Second is, for a successful angioplasty, we need to reduce the plaque burden less than 50%. And if there is a tissue prolapse, it should be not extensive. And also whether the stent wall is opposed to the vessel wall. But if it is there is 0.4 millimeter less gap, don't worry. It won't have any effect on base. So ideally, we say when the IVUS is successful, if MSA, minimal stent luminal area, is more than 5 square millimeter in a big vessel. In left main, it is 6 square millimeter, and or the minimal stent luminal area is more than 90% of distal normal blood vessel. Second is plaque burden is less than 50%, and there is no edge dissection. Third, we need to assess the complication after PCI, like dissection, thrombosis, restenosis, stent malapposition. You can see this is the IVUS picture of linear intimal dissection. So this is the intimal flap, you can see here, and there is some blood going into the flap, but it is limited into the intima. Next, IVUS image showing an adequately dilated stent with stent start within the lumen. You can see the white arrows and not against the wall. So this is the stent and this is the endothelial wall. So there's a huge gap. If it is more than 0.4 millimeters, okay. But if this is huge gap, definitely might cause SAT. So we need to post dilate it and oppose this stent start into this wall. Then third purpose of IVUS is research application. You need to drug effect on atherosclerosis. You will measure the atherosclerosis burden before starting the drug and after starting the drug for like anticholesterol drugs. Vascular response is a research purpose. This is the IVUS catheter showing how it looks like, and you can see the mainly the probe which emits the sound, ultrasound. And how do we examine IVUS? It is purpose. We have to put first a guide catheter, then we give some intracoronary nitroglycerin to avoid the spasm. Anticoagulation is needed. Then we put the guide wire, and over the guide wire, normal 0.14 guide wire, we take our IVUS catheter gently, and usually we keep it 10 millimeter distal to the stenosis. Then we pull it back, either manually or by motor pull back, and then it acquires the pictures. And then we later on we analyze the picture. And it has been already proved in all meta-analysis that IVUS guided PCI is better than angio guided PCI. So now I will share a case on IVUS, how it helped me in my intervention. Mr. X, 75 years old, came with class 3 angina, and then it revealed double vessel disease. So we did in ACS condition the SARC and staged for LND because it was calcified, and then we planned for PCA to calcified LND. You can see the calcified long LED lesion, which is 60 to 70% proximal to mid, and distally it is almost 90%. Here it is almost 90%. So it is heavily calcified. You can see that before giving dye, there is chunk of calcium showing black pictures. So decision-making process, we wanted to do PCA to LED, and our plan was IVUS guided rota, and then after doing the pre-rota, we'll do post-rota IVUS to check whether rota has successfully ablated calcium or not, whether we need to upsize our bar or not. Then predilate with non-compliant balloon, and then again after stent implanting, we'll again do IVUS, third time IVUS, for seeing whether stent is properly deployed and there is no complication. So let's take one by one. So a BMW wire taken, and you can see the IVUS, but you can see when I'm in the mid, it was stuck by calcium. When I'm pushing, it is not moving forward, and guide catheter is backing out. So IVUS, I can do IVUS up to mid portion. I can't go distal, whereas there is chunk of calcium, and you can see there is chunk of calcium here, but I can't go beyond this point, and guide catheter is backing out because I'm pushing it IVUS, it's not going front. So I have to do till half of the LED, the IVUS, and this is the live picture of the IVUS. You can see the white rim, almost 360-degree IVUS. So I had no choice but go for rotablation. Here it is almost 180, but where it is was stuck, the IVAS catheter, there was 360 degree, and it is now it's normal. It is left vein. Now, okay, so you can see this whole chunk of white calcium, 360 degree, and also you can see the negative shadow here, here, here. If it is fibrous plaque, then it will be like this mixed shadow. But when it will be calcium, it will be negative shadow and highly ecogenic. So you can see superficial rim of calcium. It is not deep. It is just then I started rota. You can see the rota bar. It is 1.5 millimeter rota bar at 180 RPM speed along with final polishing. And you can see I've done the whole chunk of calcium from proximal to distal LAD. So after doing that, after rota, I did IVAS again to see that rota has successfully cracked the calcium or not. So while you can see there are some cracks in the calcium, I'll show you the still picture, then you will understand. Here is the cracks. You can see the cracks here. If it is not cracked, then I have to upgrade my bar to 1.75. So you can see the crack here. And now evidence of successful rotablation, I determine it by IVAS. You can see there is a crack, this 360 degree calcium, there is a crack here, big crack, and there is a small crack here. And here also, you can see here is a crack, here is a crack, here is a crack. And another sign of crack in IVAS after rota is reverberation. Reverberation means there is some shadows after the cracks, and it is not a clear shadow. You will see black, then again white, then again black, then again white. This is called reverberation. So this is the signs of successful rotablation. So then I pre-dilated it 2.5 and 2.75 balloon. Always remember, in calcified lesion, you should pre-dilate with the same size balloon. The diameter will take the stent. So here I'm planning to put 2.75 long stent. So I've dilated with 2.75 15 balloon, the whole artery. And then I put 2 stents, 48 size stent. And after putting the stents, again did IVAS to see whether the stents are well opposed and there is no complication. So I'm pulling out the IVAS. Now you can see the stents. Stent start. This is the stent start. They are well opposed to the arterial wall. There is no gap. So it is long stent from distal to proximal LAD till ostium. So you are seeing somewhere this stent is elliptical, but I have measured the MSA, minimal stent luminal area. In the mid, it was more than 5. So this still picture, in the proximal stent, the MLA was almost 7.2, and in the distal picture, it was 4.2. So this is the final result after rota. You can see the whole artery is now well stented with good blood flow. Now next is OCT. What is same as IVAS, but here instead of sound, we use high resolution imaging technology that employs near infrared light. It is near infrared light. So IVAS is with sound. OCT is same principle but with light, and this light is near infrared light. So here also we can see the intima, media, and adventitia. You must know the basic normal picture of the OCT. Otherwise, you don't understand the pathology. You can see here is intima, then media, then adventitia. Intima and media is a bit echogenic, or media is radiolucent. So how would you do OCT guided precision PCI? There are several steps. First, you have to know the morphology of the lesion. Second, length of the lesion. Third, size of the stent. Fourth, co-registration. It is not available in all cath labs, but if possible, we can do it without contrast. We can put the stent. 5 is seeing the edge. 6 step is apposition, and 7 is luminal gain. So first step is let's assess morphology. Same like IBUS, there are 4 morphology. One is you have to know the normal thing. You can see so clear picture, color. This is intima, this is media, this is adventitia. So intima is a bit thick, echogenic. We say bright scatter. Media is less scatter, and adventitia is again bright scatter. And know what you're dealing. Same here, whether it is fibrous, lipid rich, or calcified. Fibrous plaque will be high reflective, homogeneous, but the lipid rich should be low reflective, homogeneous, but calcium will be low reflective like lipid rich, but it is heterogeneous. You can see this is the calcium. This is the calcium. Here is calcium. It is also low reflective, but it's heterogeneous. Somewhere dense, somewhere here. But lipid rich, it is homogeneous. And secondly, it is a sharp merging, the calcium thing. But in lipid rich, there is no sharp merging. It is diffuse merging. So thus you separate between calcified and lipid plaque. And this is the example of fibrotic plaque. This is an example of lipid plaque. And this is an example of calcified plaque. You can see calcium very clearly here. Second step is let's assess the lesion length. So you have to measure the length of the stents, and you have to know the distal normal vessel, proximal normal vessel. But sometimes in diffuse disease, you won't get the normal vessel. Then we say if plaque, wherever the plaque burden is less than 50%, this will count as a good landing zone. Maybe not excellent, but good landing zone. Step 3 is let's assess the stent diameter. What diameter we take? In IBUS, usually we measure from lumen to lumen, endothelium to endothelium. But in OCT, we measure from media to media. That is external elastic lamina to external elastic lamina. Is the difference. So how to size your stent with? It can be done automatically. You can see there's a software. You just click it, and it will do your things automatically. So here in this vessel, you can see it's 5.48 millimeter square meter. And next is co-registration, which is available in some cath labs. You can co-register your OCT with your angio pictures to precise, especially just at the ostium. And then you have to assess for any complication, malapposition, and expansion of the stent. Expansion is very important, both in IBUS and OCT, because it correlates with rhestosis and Mace rate. So you can see here the images clearly. You can see the stent start. These are the stent starts. And here is the calcium. And there is some tiny malapposition. There is a gap between the stent start and the wall, but it doesn't matter because it's less than 0.5 millimeter. And there's some tissue prolapse as well here. So after putting the stent, if you click the software, it will do your work automatically. You don't have to do anything. So it is measuring. It takes only 1 minute. You just flush you have to make the coronary bloodless by flushing with dye. Then it will have pull back, and it will give you automatically the result. You can see there is no proximal edge excision, 91% distal expansion, 100% proximal expansion, complete apposition. So expansion is related to the distal reference vessels. If it is more than 80%, I think it's enough. or 90% is very good, excellent. You can't get always the 100%. So next, I will talk about FFR, fractional flow result. Now, first two topic was on diagnostic imaging, which is dealing with anatomical problem of a coronary lesion. Now we'll talk about the physiological problem of a coronary lesion to see whether it will benefit or not the patient. We can do some physiologic test. So we can do in our out chamber or in our OPD, like TMT, stress echo, MPI, PET MB, MIB, and now CT-FFR is also available. And inside cath lab, we could do FFR, IFR, and now new thing came, BSR or NHPR. So what is FFR? It is a simple thing. It's the ratio between the distal coronary pressure and proximal coronary pressure during maximum hyperemia. This what should be added during maximum hyperemia. So what we do, we put a guide catheter, then again we put a FFR wire through that guide catheter and zero it in the aorta, then pass this guide FFR wire and distal to the lesion, and usually the pressure transducer lies 3 centimeter from the tip. There's a point there, you can see resolution, you can see. Then you will measure the ratio between the distal probe and the guide catheter probe, and then you'll put adenosine. We can give bolus or we can give infusion adenosine 120 to 180 microgram per minute, and then there will be hyperemia and the heart rate will increase, and then we'll again measure the ratio between the distal and proximal. So one is rest, one is during hyperemia. But FFR determines by during the hyperemia phase, and if it is usually below 0.80, the lesion is significant, we need to stent it. If it is above 0.80, we don't need to stent it and leave it like this. So you can see here the baseline before giving the adenosine. When you give adenosine, there is increased heart rate, and you can see gradually there is a gap between the distal pressure and proximal pressure, and we can find a significant FFR here. So we can see that in all studies, the FFR guided angioplasty is better than angio-guided angioplasty, which is published in New England Journal of Medicine. And in all the studies, DEFR, FAME2, FAME, Mayo, Van Bille, we can see that FFR guided angioplasty is superior to the angio-guided angioplasty. And it also improves outcome and also reduce cost because number of the stent decrease after using FFR. But still, FFR is substantially underutilized. Only 6% case are using it frequently. Less than 6% case, more than 10% case, some American center or Japan, not all over the world, but some country of the Europe. So how it impact our intervention, you can see in angiogram, it seems that this lesion is not significant, but FFR is 0.58. But here you can see a significant RC lesion, which I will definitely stent it, but FFR is 0.90. So according to FFR, we should not stent this lesion. This is a real life example in our cath lab. You can see 2 lesions. One is here, LAD proximal, another is SAC mid. Both seems intermediate lesion. I was hesitant whether we should do it or not. But while doing FFR, we found that one is 0.79 in LAD and 0.74 in SAC. So we stented both the lesions. And new term is coming, IFR. IFR is instantaneous wave-free ratio. Instantaneous pressure ratio across a stenosis during the wave-free period, it is during diastole, when resistance is naturally constant and minimized in the cardiac cycle. So basic is like this, that we assess a lesion significance in about 5 heartbeats without the need of hyperemic agent. So if you're doing IFR, we can do it within a minute. We don't need to give adenosine. We don't need any time. It can be done very fast. So the one problem with FR was we have to put adenosine, we have to wait when it is hyperemic. And again, some patients are having asthma, we can give adenosine. But in IFR, we don't need anything. We can do it within 1 minute. Next topic is thrombosuction. Thrombosuction, we can use different catheter like manual thrombectomy, export frontal diver catheter, and also some thrombectomy power mediated like angiogen exciser. But according to new guideline, routine aspiration of thrombectomy before primary PCI is not useful. So it is class C indication, class 3 indication. But even then, we need sometimes thrombectomy. Like here it says, if there is, large thrombus burden or saphenous vein graft, you can still use thrombectomy or aspiration catheter. So I will share a case example. Mr. Y, 48 years old, came with chest pain. There is ST up in 2-3 AVF, inferior MI with RV infarction. So when you did angiogram, you see RC 100% blocked with huge thrombus. You can see here huge thrombus burden. So we put a wire. Then we do normal suction catheter, manual thrombosuction. After doing that, you can see still there is a lot of thrombus. Here it is a lot of thrombus. So after so many manual thrombosuction, it is not clear. Then it was 10 years back, so I used exciser, and it is a motor jet system. It lies the thrombus and then suck it in. After using it, you can see it is clear a bit than before. But then I balloon the lesion, and now thrombus went to distal RC. You can see distal RC is cut off. It's ping pong effect. So one thing I must share with all of you, when there's a problem in intervention, first thing come first. So I decided to fix the proximal lesion first. At least it will save 60% of the RCA territory. Distal RCA, I will think later. So I put a stent in the proximal RCA. And you see the proximal portion is very clear, but distally there is no flow, especially the PLV branch. Here there is flow due to thromboembolism. So again, I put suction catheter, try to suck the thrombus out, but still not clear. And one thing I would like to share with my juniors that when you are doing the suction, give some adenosine through this suction catheter, then it will go distally. If you give adenosine through guide catheter, it will reach distal vessels. So again, I tried with low pressure balloon inflation, still no flow. Then at last again I used exciser, and again low pressure balloon inflation. Then at last I found TB 2 or 3 flow. Thus in this case, not all case, though it is class 3 indication to do it routinely, but not routinely, but in some cases when thrombus burden is very high, we have to use thrombectomy device. Next come IABP. Now what is an IABP? IABP means the intra-aortic balloon counterpulsation system. It's a volume displacement device. It is used to reduce left ventricular systolic volume and left ventricular end diastolic pressure and wall tension, and thus it decreases oxygen consumption. Usually it is used in refractory ventricular failure as a bridging procedure or in cardiogenic shock. So how it affects? IAP inflates the balloon at the onset of diastole and deflate just before diastole. Thus, it increases the blood supply in the coronary artery, which is fed during diastole. So coronary artery supplies the heart, and so heart functions well by getting more blood. So you need to puncture one of the femoral artery either by a needle or surgical cut down, but it can be done with a normal puncture, and then put the catheter, which is a big one, and keep it just below the subclavian artery, left subclavian artery. Then connect it to helium gas system and also to the pressure transducer. So then the balloon inflates with during diastole for diastolic augmentation, and it is ECG triggered. So ECG should be put on. You can see this is 1:1 augmentation. Now this is 2:1. This is IAP working. This normal wave. This is again IAP working. This normal wave is 2:1. Here it is 1:3. This is IAP augmentation. Normal, normal, again IAP. This 1:3 IAP augmentation. But you have to remember during patient management, during IAP, that is anticoagulation, you have to keep APDT 50 to 70 seconds, and you have to do check the pulse of the lower limb. Sometimes there is a thrombosis, and never leave the IAP in standby mode more than 20 minutes because it creates thrombus. And there are some complications as well, like limb ischemia, bleeding at insertion site, and aortic perforation. So be careful about this complication. Always give some heparin to keep APDT 2.5 than normal. Though in the shock trial, IAP did not show any benefit over control, but even it is helpful in some particular cases like thrombosuction, but it should not be used routinely. It only shown some benefit in the shock trial below 50 years old small subgroup. Contraindication, you can't put IAP in aortic dissection, in aortic aneurysm or peripheral vascular disease, or in severe AR, remember. Now I would like to share one IAP case with you. Sometime in intervention is cool in the beginning, but the scenario might change within a second. Mr. A, 70 years old, diabetic, dyslipidemic, feeling not well for last 10 years. ECG showed ST up in B2 to B6, AMA anterior. I did the angiogram. We saw that LAD 100% meet, SARC diffuse disease. So with RC is more or less normal, some disease not significant. So LAD was our main target. It is a quite cool case, though came with anterior MI. So just place the guide catheter, first shot, no flow at left main, sudden cardiac arrest, CPR started. And passed the wire in this CPR, continuing, and balloon the left main to LAD. Somehow the thrombus formed in the left main. Maybe it might come from the LAD mid lesion. It was acute MI case, or maybe heparin did not work at that moment. So one thing you have to remember in intervention, when there's an emergency, you have to act now. If you act 3 minutes later, it does not make any good result. So while continuing CPR, we ballooned the lesion, tried to restore the blood flow in the LAD diagonal and SARC. And you can see now heart is barely moving. In the left picture, we did the TPM, we intubated the patient. You can see the intubation set. Some flow in the coronary artery, but there's no pressure. And if I do intervention, put a stent in this pressure, the patient will die. So in this particular case, I took help from IAP. So you can see I did not stent. I put the IAP first because pressure was 50/30. And guide catheter I taken out because if I put the guide catheter, blood will not go to go to coronary artery. So I give time to perfuse the coronary artery by IAP counterpulsation and raise the pressure by noradrenaline entry. Next, I saw now some haziness in the distal left main coronary artery, could be thrombus. So I put a stent in left main first. Again, first thing come first. So put the stent, restore the flow. You can see IAP is still functioning to raise the pressure. Now, while after putting the stent, thrombus has gone to SARC. SARC is now 100% neat. Here, you can see SARC is closed. So in acute coronary syndrome or AMI, you always remember thrombus can cause ping pong effect. It can migrate or embolize to vessel and create new problems. So first I cleared the left main. Now I hunt for the thrombus in the SARC. So I wired again SARC and ballooned it. Now you can see SARC is flowing, OM is flowing, left main is flowing. Now I come back to the normal position where I started, left LAD mid lesion. Then I wired the LAD mid lesion, ballooned it. After ballooning, you can see it is diffuse disease in LAD. But after several times wiring, I can have some TB2 flow. So it is, as it was diffuse disease, I did not put in a stent. I just restore the flow, give some intraglyph, and then again balloon, low pressure balloon dilation, and you can see the whole LAD is disease, but now there is almost TB3 flow. So I did not stent in LAD, but there is a stent in left main, and I kept the IAP for next 2 days, and gradually I wean it off from starting. Now it is 1:1 augmentation. After 6 hours, I make it 1:2, then 1:4, then next day 1:8, then stop it and withdraw it. Without IAP, this case would have been tough for me. I could not keep the patient alive. But Alhamdulillah, by the grace of Almighty, the patient survived and went back home. Now, guide extension catheter. Nowadays, we are doing very tough cases, so we need this device to help us for support. There are two types of guide extension catheter. One is GuideLiner V3, another is GuideZilla. In our country, GuideZilla is available by Boston. So this is the picture of the both guide extension catheter. So there's a comparison between GuideLiner V3 and GuideZilla, but both are okay. So we are used to with GuideZilla. You have to be careful because sometimes it causes coronary artery ischemia, pressure damping, balloon kicking, and sometimes stent can be also be damaged while advancing through guide extension catheter. So you have to very slowly advance your stent, especially in the edge of the GuideZilla or guide extension catheter. So there is another case example, case 5. Sometimes we face a more than 90-degree bend, difficult curve from left main coronary artery to native SARC vessel. This is a post-cabbage patient. You can see there's a curve almost more than 90 degree here, and there's also calcium here. So I put a wire both in SARC and ramus just to give a good support for the guide catheter, and ballooning down of the SARC. It was diffuse disease. I needed a long stent. After balloon dilation, we failed to pass the stent through the lesion. You can see the stent is going. It is a big stent, but you can see we can pass the stent. The guide catheter is backing off, and while I'm pushing it, so I tried several times, saying the patient to take a deep breath. Even then, you can see the guide, the stent is stuck in the middle. So I took the wire from ramus and put it into the SARC again for having good support, body wire. And again, I tried, but I failed. Then I took the GuideZilla. And remember, while taking the GuideZilla, you have to take the support of a balloon. So in the wire, there's a balloon. You can see this balloon tip. And over this balloon, I took the GuideZilla to cross this bend. This bend is obstructing the stent. If you take the Godzilla without balloon support, there could be razor effect. The mouth of the Godzilla might cause dissection in the bed. So always take it over a balloon, the guide extension catheter. Now the longest stent, 2.75 48 synergy. You can see how easily it's going through the Godzilla. It's the longest stent. I first took, I think, 38, but this time I took 48. So it went very smooth. You see, it's coming, so easy. Thus, it makes difference, the backup support, and put the stent, but there is some indentation in the curve, so I have to position it to the bigger balloon, and this is the final picture. You can see sarc, ramus, all are flowing. This RSVG2 sarc was closed. Now, next comes rota. Rota is, it is a catheter-based interventional cardiology procedure with a high-speed rotational device designed to ablate atherosclerotic plaque. So there is a bar. You can see the bar. This is the bar. This is a bar. It rotates in high speed, and in the just proximal of the bar, there is some diamond chip. This diamond chip cuts the calcified lesion. So indication, especially calcified lesion, fibrotic lesion, non-crossable lesion, non-dilatable lesion, and usually we need to do rota if the calcium is greater than 0.5 millimeter deep, which is identified in OCT, and in IVUS you can see 270-degree more arc, or especially superficial calcium nodule. So contraindication, when there is a thrombus, when there is a saphenous venous graft, when there is dissections, but you carefully can do it. And components, it has got some component like this. This is all components of rotor patient. And these are the hardware: console, tank, regulator attachments, dynaglide foot pedal, and compressed air. And the air supply setup, you have to make it 90 to 110 kilopascal PSI. And this is the foot pedal, dynaglide. These are reusable. And this is the disposable item of rota. One is advancer, another is rota bar. This we don't use now, and this is a wire clip. This you have to change. These are disposable. So it is a 135 centimeter in length rota bar, and sheet is 0.058. It is diamond coated here. There's diamond chip here, which cuts the calcium. Now, mechanism of actions, it is called differential cutting. The very nice example is when we cut our beard, only the hair cuts, but the cheek does not cut, because cheek is soft, it goes away from the blade, but the beard is hard, so it is cut off by the razor. Similarly, when we do rota, the elastic tissues are cut like this, but the soft tissues goes away from the rota, so it is not cut. So it is called differential cutting. You can see we put a wire, then we take the rota bar, it rotates. Now this bar cuts and planes the calcium. Now another thing is orthogonal displacement when you open a cord. So this is the principle by which rota goes forwards. And we do rota, there are small particles less than red RBCs, it flushes away through the systems. As you can see, when you do rota, it cuts things very smoothly, not like balloon angioplasty. Now you have to have a game plan while doing rota. You have to select guide catheter, guide wire, bar selection, platforming speed, advancing the bar. You have to use the guide catheter, usually it should be coaxial, and you have to select the bar size. Usually we do now 1.5 and 1.75 bar, but sometimes in small vessels and CTO we use 1.5 bar. But now we do rota only for plaque modification, not for total plaque cutting. Guide wires are two types. One is floppy, one is extra support rota wire, but usually we use 90% cases rota floppy wire. And selecting it is bar, which I've told. Most of the time we use 1.5 to 1.75 bar. And how would operate the device? Bring the bar to the lesion, then slightly retract that to take the compression of the system, inject contrast to confirm the going of the dye, then begin treatment. Often the speed will be lower than the outside the body. So you can do at 150 to 180 RPM. Advance the bar gently with forward and backward motion. It is called peck and go, and give a gap between 2 or 3 runs just to wash out the small rota particles. And once the treatment complete, there should be no resistance and drop of RPM. It is called polishing run. And you assess the flow, assess the spasm. Complications. Sometimes there will be perforation, dissections, slow flow, no flow, abrupt closure. Now one example, Mr. X, 54 years old, came with angina on exertion. There was a LED lesion, 80 to 90%, with this long calcified lesion. Planned for rota and stent to LED. You can see LED lesion, long lesion LED. There's an aneurysm in the mid. So we went with a platforming bar proximal to the lesion, then barring it 180,000 RPM. Even after doing the 1.5 bar, you can see when I'm going to predilate the lesion, the middle portion of the balloon is not cracking. Dog bone effect. Even with 2.75 with 15 non-compliant balloon. At 28 atmosphere, I was fearing it might perforate. Then I used a bigger balloon, 350 non-compliant balloon, for giving more pressure at 28 atmosphere. Even the middle portion of the balloon is not opening. You can see here, it is not opening. So I was frustrated. I took a smaller balloon to give more pressure. Even it is not open in the middle. There you can see still there is some indentations, dog bone effect. And I used safeguard, double wire balloon, yet it did not give away. So I don't have any choice to upgrade my bar to 1.75 and did the rota again at 170,000 RPM. Even then, it is yet to open. Then I again took another high pressure balloon. Now it has given way at last at 30 atmosphere. Sometimes calcified lesion are so tough. Then I put the stent. It was cipher, I think 8 years, 10 years back. This is the last view. Last topic is laser therapy, still yet to come in our country. So it same thing. It transmits ultraviolet light, not the and what it does, it evaporates the cells. It has got 3 modes of action. First is photochemical, which it emits ultraviolet light. Then this light vaporizes the plaque atheroma, which transmits this light into thermal, and then it moves forward photomechanical. And you have to always move it very slowly to get a good lumen. So indication is usually non-crossable lesion, chronic occlusion, if it is stent under expansion. And complication is perforation, dissections, and very careful during angulated lesion, coronary dissections. So I have covered the common topics here, but there are yet some future topics to carry on, which our next generation will do, like TAVI. These are also advances of interventional cardiologists. TAVI, mitral valve clipping, LA appendage closure, impella, orbital atherectomy, LV assist device, cardiac transplant. The question is not how, but when we should start these things. and we need to record our database, and we need to protest these type of things, the falsification of the news in our country we are practicing, both from home and abroad. So take a message. We need to open cardiac surgery unit in every medical college and CCU in all districts. Develop skilled manpower, doctor, not only nurse, technician, perfectionist, and supervised training like this at home and abroad. Establish truth and protest false, like soul, chelation therapy, which are false, individual and groups like BMA, Bangladesh Cardiac Society. Implement law through Health Directorate or BMDC so that no one can practice without proper degree or authentication from home and abroad. And should acknowledge humbly to our seniors for what we have achieved and develop our juniors with love and guidance what yet to be achieved in future. So any question, please do it first, because I worked whole day for this Zoom meeting. This is my picture, but I have another thing to work now. I have to go early to clean my house at Her Majesty service. My wife, as housemaid or Kajar Bua, is on leave for COVID issues. Thank you.
Thank you, Kaiser bhai. Assalamu alaikum. An excellent presentation. I think all the participants and faculty are benefited from your lecture. You compile everything, I think big chapter, advanced technologies. You compile in a single lecture. It was 60 minutes lecture, I think so. Thank you, Kaiser bhai. Abdul, Wadud sir, please do comments regarding the lecture. Wadud sir, do you hear me?
Well, yes, of course. Everybody looks for Kaiser's lecture for two reasons. It has both educational values, it has entertainment values. Well, I don't know about the ladies. He always tries to take a hit at them. His wife must be doing something very correct or very wrong. I don't know. Whatever it is. But the point is, what he has pointed out, three things. Most of these advanced technologies are not in use in most of our centers. That's not very fair for our youngsters. They have to learn. But from where? Two, even some of the technology that can be used very easily, like FFR, are not being very wisely used and widely used. Wisely and widely. Why I'm saying so? Is there any financial conflict related to that? He has mentioned. Use of FFR leads to reduction in usage of stents. But that's for the good of the patients. Ultimately, that benefits the society and us as a whole. The third thing is, technology is advancing very quickly, and there are more things coming up. But are we using them? We are not. And we should be making a combined effort, particularly those at the helm, so that the youngsters can go ahead, can learn from in country or abroad, these new technologies can bring them here.
Host has asked you to send your video.
Please,
hello, please unmute.
Dr. Amjad, please mute.
Dr. Amjad, please unmute.
Mute. Dr. Amjad, please mute.
Okay, sir, I mute him. What is that, please?
So these are the three key things we should be looking for. We should consolidate, we should plan, we should go ahead. Kaiser, thank you for reminding us what we are lacking, for showing us what we can do, and for encouraging us with what can be done, even with our limited resources. Thank you again.
Thank you, sir. Professor Supriya Madam with us. Professor Madam, do you hear me? Madam, please unmute yourself.
Assalamu alaikum, madam. Unmute, please.
Madam,
Open camera, madam. Open your camera, ma'am.
The video to on করেন ম্যাডাম।
শোনা যায়? আসসালামু আলাইকুম।
শোনা যায় ম্যাডাম।
দেখতে পাচ্ছি না।
দেখতে পাচ্ছি ম্যাডাম।
Assalamu alaikum to all of you. Thank you so much. It is so nice talk. And after a long time, I was A to Z. I was enjoying it, learning also, and nice to see that you people are doing such a nice work in Bangladesh. Unbelievable, and I'm really happy. And I'm very proud of the organizing committee who are doing it, and it's best for the juniors, no doubt about it, and also for the seniors to update with the, because we don't have a regular communication with you, so we don't know what you are doing, in what places, what you are doing. So this is another way I can come to know that you are working very good and you are having all these equipments which I didn't have the opportunity because of my age. Anyway, forerunner has got some problem, last runner has got other problem, right? So nice to see you all, but excellent talk. And as Dr. Wadud has nicely said that yes, we have learned, we can see, and we know what is lacking and what is not. I'm sure you, all of you, will catch up in your own center with your own ability, with your own capacity. I'm sure the more center will do it, but our country is poor, and all the hospitals, those who have got private sectors, they are very difficult to make them convinced to buy this thing and do. But with your presentation, and if it goes to everybody's mind, I think this will come up slowly, but definitely surely to more centers out of Dhaka as well. So thank you again for giving me the chance to talk to you. You know that when I see all of you, I feel so good. And when I see you doing good work, I see more good, So thank you so much. At least I'm happy before I leave this world. I know I've left you and you will be doing good work. Thank you.
We are praying for you, madam. You long live with us.
I'm really enjoying Mohsin. It's very nice of you to give me the opportunity. Thank you.
Kaiser, I think your lecture will enrich our archive also. It is stored in our archive, IPDI YouTube. Every junior can hear and can teach from your lecture. Thank you. Then, Dr. Arif, do you hear me?
Sir. Yes, sir.
Yes. Lots of questions in chat box. We search the chat box and go, and then comments from the panelist.
Thank you, sir. At first, I should thank Kaiser Nasrullah, sir. স্যারের লেকচার শোনার সৌভাগ্য আমাদের কমে ছিল, এটা আইপিডি আমাদের শুরু করে দিয়েছে। ধন্যবাদ স্যার, এক্সেলেন্ট লেকচার, লটস অফ কোশ্চেন ইন দ্য চ্যাট বক্স। Most of the question you have discussed, even then I'm asking few important questions which will be helpful for our fellows. Sir, how do we measure FFR in sequential lesions or tandem lesions? Sequential lesion assessment by FFR.
Yeah. This is a difficult question, definitely. But what we do, we have to do the distal lesion first.
Sir, a bit loud.
If there is two lesions, we have to do the distal lesion first, and then we have to touch the proximal lesions.
Okay, thank you, sir.
One question related to that, somebody was asking, do you need to have IVAS for doing FFR? He asked that question.
No.
That's a very wrong idea, isn't it?
Yeah.
Yes,
Okay, I'm taking it again to clarify everyone. One is that now IFR has come. The IFR can detect every lesion separately. So the question to the first, the answer to the first question, when there is sequential 2 or 3 lesions, then we are really puzzled with FFR sometimes. But if you use IFR, it can detect every lesions separately, IFR, and we can know which lesion is significant, which is not. We don't need to do twice FFR with IFR. Second, what Wadud said, that we have to understand there is one is anatomy, one is physiology. FFR, IFR is physiology, whether we should treat a lesion or not. IVAS and OCT answers anatomy. How would you treat the lesion? So
Physiology.
FFR physiology.
Sorry, FFR physiology, and I was OCT anatomy.
Thank you, Kaiser bhai. I have a little question. What is the IFR? Difference between the IFR and FFR? Just for the exam for the junior doctors. Just
Right. FFR is the ratio between the distal and proximal pressure in maximum hyperemia. And in IFR, you don't need to do hyperemia. You don't need to do hyperemia.
Exactly.
You can do within 1 minute. Just put the wire, pull it back. It will give every lesion separately. And it is usually it measures pressure distally and proximally during diastole. There is a constant resistance in that period, and it averages the 5 heartbeats. 5 heartbeats, PD distal pressure ratio with proximal pressure in diastole.
Recently, can I add something?
Yeah,
recently,
yes,
it has come out. If you want to do FFR and you are using adenosine, you must ensure that the patient hasn't taken any caffeine within the last 3 hours, because caffeine antagonizes the action of adenosine. So your FFR results will be wrong. So you have to ensure that the patient do not take any caffeine or caffeinated drinks before the procedure, at least within 4 hours.
So one thing, sir, how much adenosine needed to hyperemia, we don't know. Sometimes 50 microgram, 200 microgram, 400 microgram. So sometimes adenosine give the false result. So IFR is better than the FFR. Arif, next question.
Sir, what is the role of FFR or IFR in case of assessment of bifurcation lesion, sir? Suppose left main with LED or left main with L6 lesion like this.
Yeah. Thank you, Arif, for the nice question. You have to do the FFR in the both lesions separately. And we need to see that whether they are both significant or not. If they are both significant and the branch is an moderate sized branch supplying a good viable territory of myocardium, more than 15%, and the territory is viable, then you have to plan ahead whether you should go for 2-stent or not, 2-stent strategy. And if FFR is not significant, or the branch, even if FFR is significant, branch is not a bigger branch, then you can carry on with 1-stent strategy. Or maybe if it is a big branch, FFR is normal, then you can go for provisional stenting as well.
Can I add something?
Sure.
Sure, sir.
Let's say in a bifurcation lesion, you have done a stenting, single stent. The main vessel is stented. Now the side branch is quite a good size. Well, after doing that, you find out it has been pinched, but the flow seems to be all right. How can you be sure that the branch do not need any intervention? Do an FFR in that branch. If it shows it's quite all right, you don't have to put in there. We should remember, we are seeing the angiogram in a 2-dimensional view. Maybe you are seeing that the orifice is pinched, but actually the actual orifice size you are seeing from one viewing point may not be that small. And the flow, if it is already maintained, you don't need to interfere in there. You do not need to use any more stent or do any post-dilatation cable kissing or anything. That's the point.
Most of the study shows it is usually for not plug shift, usually for the calendar shift. For the calendar shift, is not diagnosed by the IVAS or FFR can confirm is or stenting or balloon knot. Dr. Arun Maski, do you hear me?
Yeah, I'm hearing you.
Yeah, please.
So, how do you treat in sequential lesion? Do you give bolus, or it's preferable to give IV continuous infusions? So if you give IV continuous infusions, and then if you pull back, you know exactly what. And second is, if you have tandem lesions, we'll have to do FFR and treat the lesions which is tight, and then again do FFR the next lesion and see if that is tight, then you can put, otherwise you can leave that lesion. So I think this is a principle, if you follow, that becomes good, I think.
Yeah. It is better to do, if you do FFR, it is better to do continuous adenosine injection than bolus. Continuous is better than bolus. You're right.
And second is treat the lesion which is tight, and then after putting a stent, then you do a FFR in other lesions, and then you'll find.
Yeah. That's a good point. Good point.
But FFR usually always false impression because IFR is the good in case of contamination, I think so.
We don't have IFR, we do FFR, but not
always
regularly.
FFR is false impression.
Musky, if you have got FFR, you can have IFR as well because price is same. And you need a software to convert this FFR to IFR. You need a software, nothing else.
Thank you.
Thank you, Arif.
Sir, thank you, sir. So the another question is from Arjun. He wanted to know if LED FFR is 0.6 and L6 FFR is also 0.6, and how to select which to stand first.
How much? 0.6.
0.6, both 0.6, LED and L6.
0.6. So
0.6, 0.6 FFR.
Yeah. Then both are significant. Both lesions are significant. Both need to be done. Then we need to look for that whether SARC is an important vessel or not. If it is an important vessel and supplying a good amount of viable myocardium, and of course the lesion is also tight as determined by FFR is 0.6, we need to do the both SARC and LED with upfront two-step strategy. And if the SARC is not big one, then we'll go for one step.
Thank you. Dr. Mohsin, sir.
Arif, can I add something?
Yes, sir.
Sure, sir.
We are talking about the degree of obstruction, but you have to look at the size of the vessel, as Kaiser is saying, how much territory it is supplying and whether that territory is dead tissue or contain viable tissue. These two factors you have to take into account and then decide to which you are putting much more preference, one over the other or both at the same level. That's it.
Can I ask?
Mohsin, sir, do you hear me? Madam.
Infarct related, isn't there any point in that? If it is infarct related, then I think there is a point there that you should treat that, then you take care of the infarct related part. And I agree, the biggest vessel or the biggest supply or the viable myocardium, if you know, and from the ECG, from the echo, from the other study, then definitely, as Dr. Wadud said, it is better.
Thank you, madam.
Sorry.
Okay. Yeah, thank you. As usual, the presentation is very attractive and absorbing. Kaiser is always a real hit among the spectators. I label him as a, I think, hard rock type of presenter, not like a classical one. I would like to draw the attention to his first take-home message. It expresses because every medical college hospital should have a cardiac surgery department. But with the development or refinement of interventional technique, adult cardiac surgery scope is getting less and less by the day. But still we need some time when the surgeons need to bail us out. I remember once our respected Sophia Madam was doing a trial of Cribier commissurotome in NICVD, and in a conference, one gentleman asked Madam that if the commissurotome doesn't come to its normal position, what will you do? So I remember Professor Nobi Alam sir was there, and he stood up and told that there is a cardiac surgeon to bail you out. So we must keep that in mind. Many years back, maybe 10 or 15 years back, he told that, Madam, maybe 20 years back, yeah. So we must not forget the role of cardiac surgery. I have a question to Kaiser regarding intracoronary imaging. There are two modalities, intravascular ultrasound and OCT. Many young cardiologists are in a confusion that most of the centers can afford only one technology, not two. So if the young cardiologists want to master one technology, which is your take? Which one you advocate them to adopt?
It's a difficult question, but in our country, IVAS is easily available in many in some medical colleges like NICVD, also in some private center. OCT is a very rare one, so I should advise them to take the IVAS first. But if you say about the quality vision and seeing the coronary vessel more clearly, OCT gives a better picture.
Yes.
but OCT is still not available in our country that much, maybe 1 or 2 centers.
Thank you. Mohsin sir with us. Professor Mohsin, sir. Sir.
Yes, thank you. As usual, the Kaiser had a wonderful, entertaining lecture. Both it starts and ending. Yes, he covered almost all this advancement in intervention cardiology. If we remember 20, 30 years, 25 years back when Professor Surya started, and if you count it today, there is a lot of changes. The young generation, they are doing much, much better. But it has not been clear to us actually who are doing what. Maybe I will just have some few more idea about that advancement that is actually we are not aware of. It has been worldwide, but we are not having practice of this. Like we are not using Impala, we are not using ECMO, so we are not using like orbital atherectomy. The structural heart disease like TAVI that 3 years back I have done only one, not the much progression, mitral valve clip, not. So these are the small part, and our generation, I think, is not possible for us to continue this. I'll request the younger one to specifically dedicate it on this sort of treatment to progress further, especially the structural heart disease. And also, I think there is little bit less expensive way of treating heart failure patient in terms of stem cell therapy. That is not technically much challenging, but it needs to be trained up where it has been done, go there, stay with them for a few days, then start. These are the sector I think the younger generation will get more interest rather than practicing the regular item of angioplasty, stenting, what we are doing. If you want to be in the pace of the world level, you need to practice the whole chunk of the development that's happening worldwide. My special request to the younger generation, please dedicate yourself for a specific specialties of modern cardiology treatment. And I think we are now going to be backdated, both morally and also courage-wise. I am not going to deal with, I remember the patient in Heart Foundation, I did 9 valvuloplasty on a Friday. Can you imagine? Nobody in the hospital, no surgeon, nobody. I did 9 valvuloplasty a single Friday. But now, because of my age, if valvuloplasty come, I for some reason try to cancel it. Is there any temperature? Is there any cough? Is there any X-ray? Okay, do it tomorrow. Means that this is because of our age, we are trying to avoid the complicated. This is the time for the young generation. Those who are coming 40s, 45s, they should come forward more aggressively rather than just hang around us, because our level is this. You need to be there. So this is my request to the young generation. And thank you, Mohsin and Wadud, the wonderful get together and both entertainment and learning together in this COVID era. Thank you once again.
Thank you. Dr.
Thank you,
Shamsmonar, sir, with us. Dr. Shamsmonar, do you hear me, sir?
Unmute.
Please unmute yourself, sir. Sir,
You
please
have to
unmute.
unmute yourself.
Shazbhai, unmute করেন. Shazbhai, unmute করেন.
Oh, okay.
I did.
Okay.
Okay.
So thank you very much for the excellent refreshing course. Good for all of us, actually, even if, who are using the devices every day. I actually given a question to you. I don't think you have noticed it probably about those problem with the thrombus burden. This is a problem actually we encounter with every acute MI almost every time. And you see, after thrombosuction, when you predilate, there's actually distal embolism. what do you think about using a distal protection device if you plan to predilate such a thrombus burden artery? Because personally, I prefer, if the anatomy permits, after thrombosuction in acute MI patients, I prefer to go for direct stenting. That actually prevents distal embolization a lot. Well, what do you think? What is the opinion about that, about distal protection device or going for direct stenting?
Thank you, Shanbhai, for your nice question. I agree with you. We deal with quite a lot of time with thromboembolism in acute cases like primary PCI. So usually, if I do graft cases, sometimes I use a DPD or a distal protection device. But usually in coronary artery, I never used DPD. Though some interventions does it, but I don't have the experience with native coronary artery. I have some experience with graft saphenous vein graft. But what I do, whether it is huge thrombus burden, if I put a wire, take the suction catheter, manual suction catheter, suck it, and then I put the suction catheter distally and I give some adenosine 2 or 3 bolus, and then pull it back and give integrin half distally, half inside the thrombus, then pull it back. And most of the case after that, I do direct stenting. What you have suggested, you are absolutely right. If you do direct stenting, there is less chance of thromboembolism.
Thank you. Dr. Shomil Powell. Dr. Shomil Powell from Nepal.
Hello, sir. It's a very nice presentation. We also learned a lot from this presentation, and there were some confusions which were cleared after listening to your this lecture. Thank you very much. Very much impressed. Thank you, sir.
Thank you. Arif?
Sir.
Arif, do you hear me? Lots of questions in the chat box.
Yes, sir. Yes, sir. There are more few questions I want to ask about. One question asked by Dr. Rafi Rahman. He wanted to know about what happens to the calcium debris after root ablation, or whether any chance of thromboembolism of this debris, calcium debris after root ablation.
Thank you, Rafi, for your nice question. I really appreciate. When you do rotablation, there is some small particles which size is less than RBC. It is flushed away by the coronary flow. But what we usually do while doing rotablation, after giving 3 or 4 passes, we give a break to flush out the debris. You don't do rota like in a go 10 or 20 times. You do 4 or 5 runs, then stop, give a break, let the coronary artery flush out by normal coronary systole and diastole, then you do again if needed. So you have to give some break between 3 or 4 passes.
Thank you.
Dr. Rehan wanted to know about the IFR and FFR. He wanted to know what wave those indicate in case of IFR. That is, in case of whether there is FFR and IFR doing simultaneously or alternatively.
No.
FFR and IFR.
IFR is done separately. You can do FFR, which is the old one, and the new one is IFR. In FFR, both serve the same purpose, Ryan. They know the physiology of the coronary blood flow, whether we should treat a lesion or not, whether it's important or not. You can do only one of them. You don't need to do both of them. But IFR is easier one because you need less time and you need not to give adenosine or make hyperemia. This normal physiological systole diastole.
Okay, thank you. Arif?
Sir, Rehan has another question. Is there any correlation between FFR and MPI?
Yeah. Both are physiological testing. The intracath testing are IFR, FFR, and extracath testings are MPI, TMT, or lobotomy testing of both are showing you whether a lesion is significant or not. But IFR or FFR is more specific. You can say this lesion, this artery is producing this ischemia. But in MPI or in TMT, you can specify lesion like IFR.
Yes, sir. In that regard, can I ask you a question? Let's say a critical lesion, but it's proximal to a dead area because it's infarct-related artery. What will be the IFFR showing in there? Because the flow is already limited. the tissue is not viable, the tissue is not there.
Usually, this is if it's dead tissue, then we should not do it. That's my answer. I will not do an IFR or FR in a dead tissue. If I know that this is infarct area, this is dead tissue, then I won't do it. To measure dead tissue, I usually do some non-invasive test at Bangladesh perspective. Like if there's a MI, I see that in the ECG, in the B1 to B6, there is R-wave khota ase kina, there's a small R-wave or not. In echo, I will see there is a hypokinesia, echinacea or not. And if I do MPI, then I can get better picture. But if it's dead tissue, I will not do any IFR in that particular question.
Because I asked this question, once somebody asks is whether the MPI and the FFR, each test serves its own purpose. We have to understand why I am using that particular test.
Yes.
I got it. Thanks. I got it.
Yeah. Arif?
Dr. Parag Karki wanted to know about the shockwave lithotripsy and its use in lesion preparation or calcified lesion preparation. Shockwave lithotripsy. Few words about it.
Yeah. Thank you so much, Parag Karki. I think he's from Nepal. Thank you for being with us from such a distant place. I really appreciate. Lithotripsy balloon is a new modality for calcified lesion. And it is very easy. It's called shockwave lithotripsy, which we use in the, for crushing the ureteric stone. So we put a wire and over it we took the shockwave, the shockwave balloon, and we connect with the console, and there is a shock there, and it cracks the calcium, and we then dilate it and put the stent. So it's a very useful, but one thing you have to understand, for shockwave lithotripsy balloon, you need to have you need to take the balloon inside the lesion. Sometimes it's a bulky one. Sometimes the lesion is so tight, you can't take the balloon inside the lesion. If you can take it, you can do it. If you can't take it, then you have to go for rota or orbital lecture.
Can I add something?
Yes, sir.
Sure, sir.
If the calcium is superficial, then you can use the rotablator very easily. But if the calcium is deep, the rota cannot reach there. In that case, shockwave lithotripsy actually better. And actually, these are complementary. Rotablator and shockwave lithotripsy. We are not sure about its use yet because we do not have the technology here. But I'm very interested in that. I hope our youngsters will be using that very soon.
About complication, which is safe? Kaiser bhai, for the rota and lithotripsy.
Of course, the balloon, the balloon is relatively safe.
So far.
With rota, you have to be very careful, especially in the curves.
Mohsin, will you say something?
Yeah, I think lithotripsy, that intravascular lithotripsy, it can change the use of rotablation. Because what calcium we are seeing both superficial and deep. Superficial calcium, yes, as I have seen the one case with shown by Kaiser using 3 bar, 1.5, 1.275. So even then there was a indentation of the balloon, and we have got less opportunity of yet available non-compliant balloon up to 24 safely, but beyond that it is a risk of rupture of the balloon. So these are the balloon. There is a double layer balloon. It can go up to 45, even more. So that helps in cracking the lesion. So there is what we call OPM balloon. That is one issue. That can crack both superficial and deep. But the other one, the lithotripsy balloon, it doesn't need this much of pressure, rather 6 to 7 atmosphere. But the ultrasound, that actually crack both superficial and deep. So chances of vessel rupture is less with this intravascular lithotripsy balloon. I think it can. Anyway, the rotablation will not much debulk the lesion, calcium, rather just make it a smooth. But the main role is done by the balloon to fully completely expanding the vessel. Unless you completely expand the stent, the chances of restenosis, chances of stent thrombosis, all complications rise if the stent is not expanded properly. So in that case, I think this high pressure balloon, the opium balloon, and intravascular lithotripsy will definitely superior than this rotablation. This is my thinking. Hopefully it is not, and also it is also very user friendly.
Yes,
You need a good synchronization between the operator and the assistant in handling the rotablation. But this device is very simple. Yeah, thank you.
Madam?
I was wondering, the lithotripsy balloon is definitely promising, no doubt about it. But it is price-wise, anybody has any idea the rotabar and the balloon? Any comparison is done?
Yeah, the price is very high, more than rota. It is because of their marketing. Initially, they had been invested a lot, so they want to reimburse it from the. But it is more expensive in India. I think one is 2.5 lakh.
In INR.
And it can be used only in one patient.
One patient, right?
And it is simply a disposable one. So in that case, it is expensive.
I think if you have got a vision to do that, intention and dedication, I'm sure it will come. Price is not a problem.
Yes.
Price is not a problem. It is much safer and friendly. What I saw, the presentations before, is much safer and friendly as well for the patients. Also, price will not be a problem. As I said, of the dedication, inshallah, you'll be able to do it. Thank you.
But I would like to add 2 points here. One is it is a bulkier balloon.
Yes.
You need to take the balloon inside the calcified lesion. Sometimes when there is a calcified specule, you can't take it inside the lesion. Then it won't work if it don't go inside the lesion. One. And second thing is that it works well with concentric calcium. If the calcium is eccentric, it works less.
Yes. Dr. Kobe, do you hear me?
Very correct. Very correct.
Dr. Kobe? Dr. Kobe Hossain? No. Dr. Nasrullah? Yeah. What's your question? Yeah.
It's very nice to hear from Kaiser Bhai. He's not only pride of Chittagong, he's pride of the whole country. And he is a mentor of many of our young cardiologists like us. And it's very nice to hear from you and such nice delivery from him. So I really enjoyed. I don't have any question. Thank you very much.
Thanks, Anis.
Arif, any question left?
Sir, one more question. Dr. Virat wanted to know a very, very basic question and regarding IVAS. What will be the post-stenting minimum lumen area target for different vessels, especially left main, LAD or L6?
Very basic question.
Post-stenting MLA.
Yes. It's a very good question by Virat. Thank you so much for asking to me. And thanks for joining us from Nepal. After stenting, we need to expand the stent well. So this well expanded stent is correlates with maze and restenosis. So minimal stent luminal area usually should be above 5. And in left main, it should be above 6 millimeters square meter. And if you can't do it, especially in distal vessel, where the vessels are small, then you have to achieve 80% of the luminal stent luminal area of the distal normal reference vessel. These are the two targets. 80% of the distal normal reference vessels, or 5 in normal artery, 6 in left main.
Thank you, sir. I think we have covered most of the question. Proceed,
Dr.
sir.
Mahura Babu?
Professor
Dr. Mahura Babu?
also here.
Thank you, Mohsin. And Kaiser Bhai is my elder brother, and he's doing well all the time. Today, his delivery, I would like to thank him for his nice delivery and time-worthy presentation. And I also congratulate the organizer, especially Wadud sir and Mohsin, Arif, Monwar, and Khalid Mohsin Bhai for organizing such a nice session. It's very, very benefited for our students. And thank you, Kaiser bhai. Thanks.
Thank you.
Thank you. Dr. Khalikujon bhai, do you hear me?
I can hear you, and thank you all the organizers for arranging such a brilliant lecture, wonderful lecture given by Dr. Nasrullah Khan, my dear friend from student life, and really we learned a lot from him, and always we used to learn a lot from him. I have got two simple questions to him. Number one, can FFR detect the viability of the myocardium? Number one. Number two, why we are going to stand the diffuse lesion by IVAS? How can you determine the landing zones?
Thank you. Thank you. I will take both questions. Number one, about the IVAS, when there is diffuse disease, there is no normal reference distal segment, then we will put our stent distal edge to where there is less than 50% plaque burden. Less than 50% plaque burden. First, you will target to land your stent in the normal reference vessel. If you don't get a normal reference vessel, there is diffuse disease, then you will land your stent with optimal pressure where is less than 50% plaque burden. This is the second question. And first question was about FFR. What did you ask? Khalid, can you please repeat the first question?
I will
Can we detect by FFR can you give can have any idea about the viability of the myocardium by doing the FFR, or only we can assess the significance of the lesion?
Only lesion.
It only gives you the significance of a lesion. This is just simply a ratio between the distal pressure with proximal pressure. That's it. In FFR maximal hypertrophy.
Thank you.
Dr. Khandukasan.
Can I add something? Can I add
Yes, sir.
something? Regarding the diffuse disease, recently Professor Antonio Colombo was present in a seminar, and he was telling that for this type of lesion where we are not sure where we can land the stent safely, and it's better to use drug-eluting balloon. And he has shown in many cases where using drug-eluting balloon 1:1 ratio, full pressure for longer period, and the patients are doing very well. And even with minor degree of dissection, if it doesn't create any flow limitation, here the FFR comes into play after balloon dilatation, then don't put a stent in there. And it will heal very naturally. And the patient, they have done some post-procedure angio at 6 months follow-up. They are very nicely done. I hope this method may become quite popular in future.
Thank you. Assalamu
alaikum. Thank you, Mohsin bhai, for giving me the time to talk something in front of you. Actually, I have heard lots of debates regarding the use of IVAS and OCT as well as IFR and FFR. I have some comments regarding the first issue, that is IVAS and OCT. Actually, both this one cannot replace the others. Actually, one can supplement the others. This is the main thing. First of all, if you think of the ostial lesion, if you think of the CKD patient, you should consider the IVAS. Actually, there is no role of OCT. But on the other hand, OCT gives more information regarding the soft tissue. There's like plaque, clot, or intimal.
Hematoma.
Yes, dissection is the soft structure. And number one. Number two, it gives at least 10 times more better resolution than that of the IVAS. This is the more advantageous. And second one, it gives faster result. And on the other hand, IVAS gives more information regarding the plaque burden, that is the calcified plaque burden. As you know, IVAS gives message from 4 to 8 millimeter inside the vessel's wall, but OCT only gives 2 to 4 millimeter plaque burden. So for maximum, so if the issue is the plaque, to assess the plaque burden, in that case, IVAS is superior than the OCT. This is the one reason. And on the other hand, another question arises regarding the IFR and FFR. Actually, in that case, IFR is very good because of there is no use of adenosine or other hyperemic agents, number one. Number two, it is the time consuming, less time is required for IFR. Number two, in these two reasons, this is the superior than FFR. But the question is when it is in the gray zone. That is, if it is 0.86 to 0.93, this is the question. In that case, IFR can supplement by using the FFR also. That is the hybrid IFR FFR. In that techniques, if you use the hybrid IFR and FFR, we can optimize the lesion. We can assess the lesions more accurately, as because IFR can give you only 83 to 84% specificity or sensitivity. But if you use the hybrid IFR and FFR, we can reach up to the 94% sensitivity. So this is my comment. And lastly, basically, Kaiser Nasrullah sir is the iconic presenter of this country, no doubt. We have learned a lot from him and enjoyed the program very good and very informative way. And special thanks to Dr. Mohsin Ahmed and our respected Professor Abdul Chowdhury sir. And simultaneously, I also like to thank Dr. Arif, who is a very good.
Thank you, sir.
Very good presenter as well as very good communicator. Thanks, everyone.
Thank you, sir.
Professor Amal Kumar Chowdhury, sir.
Thank you, Mohsin and Professor Wadud Chowdhury for arranging this type of IPDI under the IPDI. আমি কিছু বলতে চাই না. I like to celebrate Kaiser Nasrullah Khan for his excellent, brilliant as well as very advanced technological presentation of our interventional cardiology. আমি একটু পরে জয়েন করেছি, একটু পরে আমি একটু ট্যুরে ছিলাম, আজকে আসছি. আমি একটু দুইটা কমেন্ট করতে চাই. একটা হচ্ছে যে নিউ টেকনোলজি কমপ্লিমেন্টারি টু দা upcoming technology, complementary to the rotablator. That is, this technology name is IVL, not balloon or not shockwave, like the IVL, intravascular lithotripsy, IVL. And it is marketed by Lumina, TransLumina. And I have an opportunity just before Corona situation. I joined a 2 days workshop, live workshop in IVL. To me, it is that IVL is going to be replace the rota. Very soon it will replace the rota. Only bar is the already discussed the price.
Cost.
And number two, I like to small comment. Mohsin is very inclined to IFFR. I think from the lecture, I think he's telling every time that IFFR is instant FFR is very good than older FFR. There is also two type of FFR, RFFR and CFFR. আমি আর ডিটেল যাচ্ছি না. FFR নিয়ে কিন্তু কন্ট্রোভার্সি এখনো চলছে. তো আমি নাইস অ্যারেঞ্জমেন্টের জন্য আমার মনে হয় আমার সব আবার কাইসারের লেকচার দিয়ে আমার রিক্যাপিচুলেট হয়ে গেল, একবার রিভিউ হয়ে গেল. থ্যাংক ইউ মহসিন, থ্যাংক ইউ ওয়াদুদ, থ্যাংক ইউ আরিফ, and also my younger brother Kaiser Nasrullah Khan.
Thank you, sir.
Thank you, Kaiser bhai. I will just always IFR FFR is confusing in the lab for me. Always false negative, false positive. Is a teamwork. How you more accuracy, increase the accuracy of the FFR is in your practice for the juniors.
Actually, to be honest, these things we use very less. I think hardly I have used in my 2% of intervention. The IFR is not yet available. We have bought the machine. We will start within a few days. But FFR I have done in last 2 years. I can remember, I think maximum 8 to 10 cases, not more than that. So we should use it more often, and we should, for accuracy of the system, we should follow the protocols. Protocols means to take the wire properly, zero it before entering into the left main, and then properly producing the hyperemia, that is adenosine continuous IV infusion. If you follow the protocols, it can be, we can reach more accuracy. And I think IFR will give us more better result, which I believe. And yes, I do agree with all, whatever Asad shared, Muta shared. There are different systems, each complement with each other, but practicality is you can't have all the systems in your cath lab. It's impossible.
Yes.
Even in the best center, you can have only one. So you have to choose between IFR and FFR. You have to choose between IBUS and OCT. So maybe you 10% case you won't get the good result, but 90% case you can do with this. But one is anatomy, one is physiology.
Thank you. I have a question, Dr. Shams Monwar, sir. Do you hear me? Sir, please unmute.
Shams Bhai is the only person who is doing exercise, aerobic exercise, while
always exercise, doing exercise. Sir, do you hear me? Please unmute yourself. I have a question. If endothelial dysfunction, how you equate the IFR or FFR in case of endothelial
about
dysfunction?
this IFR, let me tell you the first thing is the clinical information.
Yeah.
Whether you've got a suspicion of ischemia or not, that's the first thing. I mean, you start one by one, stating on clinical ischemia is there, evidence of ischemia is there. The patient of medical treatment still encountering symptoms. Then what I do personally, I do the IFR first, the easy thing. If IFR settles the question, then go ahead and do the revascularization, stenting, or whatever it is. If the IFR is the question, the problem comes if the IFR is borderline. The IFR is borderline, then I go for FFR. I give a good dose of adenosine, bring the heart rate down to around 30, give a good hyperemia, then check the FFR how it is. That usually gives enough information for us, whether the patient needs revascularization or not. That's my practice from all the experiences how I do to check the lesion status. But the most important thing is the clinical information. Plenty of times I've seen the angina is there, IFR is not bad, borderline, and then I do the FFR becomes significant. I've got quite a few experiences about that.
In case of endothelial dysfunction.
Endothelial dysfunction, well, first of all, I mean, endothelial is a different matter. It's nothing to do with this IFR blockages. Even without blockages, you can have endothelial dysfunction. If you see slow flow, you can have the angina, even without any plaque. Those are due to endothelial dysfunction. Their assessment is quite different from the topic discussed today.
Yes.
So I'll not go. That's a very big issue actually. So I can't actually discuss that right now. But the endothelial dysfunction is a completely different issue. It's nothing to do with the blockages.
Yeah.
My important thing is clinical information. What is the clinical problem? That's the important thing.
Can I ask one question?
Yes.
My question is specifically to Professor Wadud, Professor Mohsin, Kaiser Nasrullah Khan, particularly these three people. If any modalities of investigation or treatment after invention of 5 years, if 80% of user cannot adopt it, what is the utility of this technology in any binding, due to complexity, due to cost, due to demand and supply, due to some constant, any constant that we can 80% of the user cannot adopt after invention of any modalities of investigation, modalities of technology like FFR, IFFR, OCT, IVL, and more things. So in convention of the medical ethics, if any modalities of treatment or investigation does not adopt by 80% of the user, it is usually it is a fashion, not actually effective for the management or for the treatment.
Sir, I first answer your question. Then Wadud sir. I first answer the question. It is, I think, most important is the financial constraint. In case you go to the Korea or Japan, they are doing every case is the IVAS. If you do the IVAS, the post-testing dilation is the 100% accurate. Without IVAS, you cannot do the left main. So why you cannot say, because our in the poor country, so you use the stent boost, you use the clinical assessment, but this all the medicines are invented due to the patients, improve the patient symptoms. Wadud sir, do you comment, sir?
I'm agree to Mohsin, but except Japan, you go to USA, you go to Europe, they are doing left hand without bypass. Imad Shivan laboratory, cath lab, I did work for 3 or 4 days. They are doing randomly a left hand bifurcation lesion without p-dilatation, without IVAS, without OCT. In European country like Italy.
Because
so,
there is the insurance coverage is the most important, sir. There's the insurance coverage of the IVAS. Is the problem, sir. Wadud sir, you comment?
Let us be philosophical. I'm at this level, but why shouldn't I aspire to be at that level? In this country, when the standing first started, people were saying, well, it's a fashion. How many people can afford it? Now, patients come to us telling that I have 40% lesion, 50% lesion. Should I not put a stent in there? We have to dissuade them. No, we do not need that because the blockage is not that severe. So we are financially constrained, but are we not improving? Yes, we do. And we have to aspire to that level. And when a technology becomes more widespread, it becomes cheaper. The computer you have bought at your student time compared to today's pricing, that was very costly. Today, that computer has come down quite low, isn't it? Exactly. Today, the machine we are buying is a very high-grade machine compared to the old one that we have used during our clerkship or studentship. This is so. And another thing is that, yes, technology will differ from country to country. We shall adopt to 3 things. 1, what is our ability, finance-wise? 2nd, what is our expertise? 3rd, what is the acceptability? Cultural acceptability is a very important thing. Why intervention has progressed so much in Japan? Because Japanese people, they do not want to open up their body. They think it desegregates the body temple. It's like that. That's why intervention has progressed so much in there. They're very much willing. The government is willing. Everybody is willing to put money in there. But the financial constraint in this country is putting us at jeopardy. I was talking about FFR or IFR. Why am I interested in that? It has been shown, even in triple vessel disease, if you do the FFR, you can decide among the 3 vessel disease which 1 or 2 vessels you need to actually open up, because that will substantially reduce the long-term pressure and gives you the better outcome in the long term. This is what we should be doing. We should adopt that technology which actually serves longer term the patients, also us. That's my point.
Thank you. Last comment from the Dr. Kaiser Nasrullah Khan. Yeah, we are already 2 hours, I think.
Thank you, Amulda. First, I will comment about Amulda. He's a very favorite senior guy. If you say Mujumdar sir is the individual of cardiology, I will say Amulda is the individual of interventional cardiology. I don't think he has missed any seminar or symposium from all over the world. Secondly, you know, in this COVID era, there are new fashions. Amulda has become bald-headed, I think. Is it a new fashion, Amulda? Okay. Now, answering to the question, I totally agree with Wadud bhai. You have to dream big. You have to dream big. You can't say that I don't have it, but maybe I don't have it. My junior will have, or maybe third batch will have. I will start the path. 1. And second thing, if we have these things even in Europe, America, all the center doesn't have this all modalities. There are tertiary care center where maybe 10% cases who really need these devices to decide. 90% case we can do without maybe with our basic infrastructure, but 10% case where multivessel disease, whereas borderline lesions, there we need to, or complex lesion like left main bifurcation lesion, we need this IVAS OCT or IFR things to do. So maybe 8 to 10% cases. Thank you.
Chip PCI is very needed. All technology is needed in chip PCI, high risk PCI. All the technology we can apply. All the.
I agree. I hope the new platform BCIC will provide us with these new technologies. The precision of PCIC.
Thank you.
Well,
Thank you. Last comment, Wadud sir. Yeah.
I think we have spent enough time talking about the issues and also about the philosophies of treatment and everything. I think enough has been said. And Dr. Kaiser Nasrullah has beautifully presented modern technologies. He has left out many which has not come as yet in this country, may not come in near future given the corona situation. But the last word is we should be aiming big. That is Professor Sufia Rahman. She started, taken a small step, has taken enough stress mentally, physically, and now look at us where Kaiser is going ahead, where our juniors will be going forth. As I was telling, we should give them the platform to build up more. We, when we get older, when we want to get treated ourselves, we want the best interventionist. We want the best of technologies. We want the best services. To that end, we all should aim not to serve only others, but also to serve ourselves by improving the knowledge, by improving the skill, by improving the environment in which this academic meritocracy can flourish. Good night, everybody. And I think I'll be taking leave of everybody. Thank you.
Thank you, sir. Thank you, sir. IPDI work on it. Thank you, everybody, especially participants. Last 3.5 months, they are with us. I thank and grateful to the participants. Also, our honorable panelists. I thank Professor Sufia Rahman, Professor Nasrullah sir, all the senior teachers with us, Professor Mohsin Jaman, Sounds Pona, everybody. Our next class on 16th August, acute heart failure. Talk on Professor Amrozul Islam, sir. 16th August on Sunday at 3.
Mohsin has been muted.
30 p.m. And take care, everybody. See you on 16th August on 3:30 p.m. Assalamu alaikum.
We should thank INSEPTA as well.
Oh, I thank INSEPTA. INSEPTA, they did a tear-up man's tremendous job. Okay, thank you, INSEPTA.
Good night, everybody. Assalamu alaikum.
Good night. Madam, assalamu alaikum. Arun Maski, goodbye.